Dr. Tina, my God, it's been a long time in the making of us actually sitting down to have this conversation, but I'm beyond excited to have you on the show and dive deeper into the microdosing of GLPs. Now, just to kind of set it up real quick, because of you, I went down that rabbit hole and I was fascinated. I'm very open with my audience. I tell the story quite often of how when Manjaro first came out, I tried it because that's what we do. We're biohackers. We experiment on ourselves, right? Like, let's give this a shot, see what happens before I recommend it to people. And I did the full 5 milligram dose. And
Ooh.
I shit you not, it was 2 weeks after Atia had released that article on, we're starting to see about a 40% lean muscle loss. That was like, at first I was like, Peter, you're really hot, but you're wrong. Like, I'm not seeing any kind of muscle loss. And 2 weeks later, I'm like, I got my mom's arms. Like,
Yeah.
I'm seeing the skin. I'm losing muscle. Oh my God, what is happening? So I was kind of like, I wasn't anti GLP at all, but I was like, some things that need to be worked out here. And then fast forward to your information, the microdosing of GLPs and going down that rabbit hole. I'm like, okay, well, this is fascinating. And now I do the correct microdose and it's entirely different. No muscle loss, muscle gain.
Yep.
I have an amazing metabolism. I mean, I eat well anyways, but I can have my sweet potato fries. I can have a glass of wine. I'm not 10 pounds heavier. So first of all, welcome to the show. Second of all, thank you for opening my eyes and the eyes of many out there.
Oh, right on. That makes me so happy. That makes me happy. My goal was to share the information that I kind of cooked this up in my head, this idea of the way that I've always treated clinically was addressing hormonal deficiencies, even if they were just tiny and physiologic, even just tiny, because
Mhm.
my background was that I did regenerative injection therapies. So I was doing prolotherapy, PRP stem cells a long time before it was popular. And I'm talking decades before it was popular. And I found that very often patients needed just a little sprinkle of maybe some thyroid hormone or maybe just a little. I'm a big thyroid, like yourself. I that was, that joke amongst my colleagues was Dr. Tina thinks everybody needs thyroid. I'm like, well, they pretty much do.
You do.
So,
I agree. Yeah.
but a little sprinkle of estrogen or progesterone, testosterone, whatever they needed, just produced remarkable outcomes. And I was dealing, principally with musculoskeletal pain. So that's a pretty good gauge. Like if their pain's gone, we're on the right track, right? And so then with this GLP-1 thing, my podcast producer just kept saying we need an episode on Ozempic, and I'm like, I'm not going to talk about something I don't entirely understand. So I dove into it, and I just found I always go top down whenever I research something. So I immediately want to know what it's doing to the brain and then to pain, because that's my world, right? Brain and pain, and your pain's coming from your brain. And even if your joints messed up, like it's about central nervous system stuff. And so I was flabbergasted at what I was finding, and it was not at all what we were being told. And I started thinking, what if I approach this like I approach everything else, which is just sprinkle a little bit on and see what happens. And my version of microdosing and the versions that we're hearing about out there now, I don't know how you do it, but man, I'm hearing like some of these bro science guys, they're talking about taking a fairly standard dose, even if it's a low dose, and then they're breaking it up almost every day. I think that's completely unnecessary with how long the half life is of these. I think that's a bit ludicrous. And we're also hearing people like it's the inmates are running the asylum. Folks on TikTok are like, I'm taking this dose, but I broke it into 3, so I must be microdosing now. I'm like, no. And then there's a lot of doctors using the standard starting dose and even going up a tier and calling that microdosing. And that is not at all what I was after either. What I'm talking about is like a fifth or a tenth of the starting dose. And that is not a weight loss strategy. It is a whole different ballgame. I was using it for neuroinflammation, pain, autoimmune disorders, PCOS, cardiovascular support, all the things I was finding in the literature at just fractions of the standard starting dose. And if you do all the other in a metabolically optimized person, which is who I only work with anyway, I don't work with folks that are really in a pathological state of metabolic compromise because you can't do regenerative injection therapies on those people and have it work. So taking your, basically you're like women like us who are doing all the things already.
Mhm.
Um, and adding a little sprinkle of GLP-1 on was just maybe, for in my case, I have psoriatic arthritis, I have neuroinflammation, I have chronic pain, I have low mood and from the neuroinflammation. And so all of those things into consideration. I do think some folks who are more compromised metabolically probably do need a bit higher dosing, but even in those folks, I have found that we really don't even need to go very far into the standard dosing if, maybe the first tier or two. I know a lot of docs are doing that. I think what was novel about what I was trying to speak on originally, which was I was not using microdosing again to just reiterate as a weight loss strategy. We didn't really have much weight to lose. We maybe 5 or 10 fluffy pounds from menopause.
Mhm.
Where I myself was starting to go down that shift from that gynoid curvy shape into that android, sort of belly heavy shape. And that's just how I'm built. I'm built like an apple. And I was turning into like the little potato shape of menopause. And so for me, it was really nice to have that reverse, but that also required all the other hormones and some other peptides and all the things, as I call it. So I look at microdosing as a tool within a comprehensive treatment plan, not as a standalone monotherapy, which is, I know you and your audience get this, but a lot of folks aren't hearing it. They're thinking, "Oh, I'll just microdose for weight loss," and then they complain that it doesn't work. And I'm like, "No, I never said that." you know,
Yeah.
it it might give you a little bit of weight loss if you're already metabolically optimized. You might enjoy that part of it, but like, I still have a little fluff on my tummy. If I want to crank the dose up into a little bit of a side effect profile, I could probably get that off. But I also will start to lose muscle, and that's not what I'm going for. So
Hmm.
anyway, that's now I'm here. So I'm excited. I know it took a while to get me on here. I'm appreciative of you being patient with me, but I think it's cool now because now we have so much data to support everything I have been trying to say. So I feel like it's actually a good time.
Yeah. No, I love it. I love it. And I'm happy that you mentioned the different metabolic states. So we have to break that down for people. You have the
Yeah.
subset of people that have the full blown type 2 diabetes. They are metabolic disasters. And they might be taking metformin. Maybe they're working on their carbohydrate intake, whatever lifestyle changes they're doing. And then you have and those people might need or do need a higher dose, the standard medical dose that your doctor will give you, the 5, the 7.5, the 10, if we're talking tirzepatide, the higher dosing. Then you come over here and you have that subset of people that they just want to improve their health. Like you said, Tina, 5 pounds, 10 pounds, extra fluffy weight, menopause, perimenopause, inflammation. These are the same people that are being prescribed antidepressants instead of fixing their thyroid, fixing their hormones, where
Right.
GLPs can actually help with that too. I want to get into the brain and mood. But it's important to separate those two out and then go one step further. And I'm sure you've seen this as well. But then I see the subset of people over here that are not totally metabolically broken. They have a little bit of insulin resistance because their thyroid is jacked, their hormones are low. They're not over here in the obese type 2 diabetes camp. But these people, they'll come to me before they have their thyroid optimized, before they've addressed their hormones. And they will be the ones that will say, I tried a full standard dose of Monjaro, Ozempic. It didn't work. And I'm like, well, that's because your thyroid's in the toilet.
Right.
You have no hormones whatsoever. No wonder you're insulin resistant. I know you're doing carnivore and keto, but you're still insulin resistant. That's why it didn't work. You weren't doing all the things. You were doing one thing and crossing your fingers and wishing on a rainbow that this would be the miracle that the media portrays it to be.
Yeah.
It is a miracle when done properly, but it's not going to be a miracle to and override good lifestyle, thyroid balance, hormone balance. So
Yeah.
I'm happy that you brought up those two subsets of people. So with the metabolically broken people, are you okay with them doing that higher dose?
So I think of it really as three types of patients, and very similar to what you said. Type one would be folks like us who are strength training several times a week. We're eating a high protein, low carbohydrate diet. I do think that you actually, I mean, just as a side note, you really, just so the audience understands, you really can actually throw yourself into further insulin resistance with a carnivore diet, depending on how your body wants to deal with that arachidonic acid and where your adiponectin is. So, just to go back to what you're saying, you throw those people on a high dose of GLP-1s and it doesn't work. And I'm like, "Yeah, we got other things to talk about, like, and all your hormones, right?
Yeah.
But type one folks are, patient type one would be, we are already on the HRT. We are already optimized our thyroid and our sex hormones. We are already doing all the things, and things are still starting to go awry. Even the gals with the six pack abs, as they get a little bit older and into menopause, can start to exhibit some cardiovascular markers are changing. Some blood sugar markers, metabolic markers are starting to change. And they're like, what the F is going on here, right? Like my cholesterol started going down even further, but then my LDL was going. I have a low cholesterol, just I cannot get it up to save my life. And I realize there's probably other issues there, but my LDL was going up. Things were just starting to get out of balance across the board on my labs. And I was like, oh God, it's happening. And you start to thicken up a little usually. And I call it the thickening. It's like the middle age thickening. And your female listeners probably know exactly what I'm talking about if it's happened to them.
Mhm.
And I was like, oh God, the thickening has begun. And with it came a ton of pain. And there were issues to be addressed. And even with all of my tools, I literally have access to the best tools on the planet. Nothing was working. And so I thought, I'm going to sprinkle a little GLP-1 on this and see what happens. And voila. So in those folks, it tends to work very well. In subset two or type two, I think of that more like your average American woman who probably follows us on Instagram, and they're thinking they're doing all the things, but they still haven't met with someone like you or I and gotten their hormones handled. And so they're like, but I'm doing everything right. And I'm like, you're missing a huge part of the equation, which is the HRT, and we'll clump thyroid and adrenal support into that, you know?
Mhm.
And they maybe have 30, 40 pounds to lose. I still think a very low dose strategy with them, even maybe a microdose, depends on how their body handles it. I'll just interject here really quick. I do think there's functional deficiencies, just like there's functional deficiencies of other hormones. And it's only the functional medicine endocrinologists that I've talked to that really will back me up on this, because everybody else in the world of obesity and endocrinology and the allopathic community thinks that this is nonsense. But it's absolutely true that we can functionally sort of eat, live, and stress our way into some of these hormonal deficiencies. And some of these are signaling peptide hormones, you know? So anyway, when we think about leptin and ghrelin and all of that, like, maybe they're not being heard right. Maybe they're not being produced right. Who knows? I don't know. But I thought this group in the middle would be just prime for that very, very low dose or even a microdose. And it should work if they start doing all the other things and all the other pieces are addressed, including gut health, including, strength training and adding muscle. And then there's the type three, and this is where everybody is looking because this is the bulk of Americans, and we're outsourcing it across the world, which is this really pathological state of metabolic compromise. And when people get to type 2 diabetes, it's been a 10, 20-year journey there. A lot of damage has been done, and they are absolutely in a devastated metabolic and mitochondrial state. And it's very pathologic. And so those people are needing the higher doses. And to answer your question, I still think every effort should be made to keep the dose as low as humanly possible, because I think that the receptor resistance possibility is real. I think it's happening. And I think at too high a doses, these peptides might be very much catabolic.
So are you
And
actually seeing people getting used to them and needing higher, 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 higher?
yes,
Oh, interesting.
or I'm
Okay.
seeing some of my girlfriends on the internet who I know went up to the full dose. And now when I look at them in their pictures, I can see they're backsliding and they have nowhere to go. And then I've talked to some compounding pharmacists who dispense a whole lot of these. And they're telling me people are calling saying, can I go up? Can I go up? I need a stronger dose. So I do think that there's receptor resistance. And the longer, so we just had that study come out in mice where basically the cardiomyocyte shrinkage, you probably heard about this. Your audience, I'm sure, has. It shrinks the heart. What they did to these poor mice was gave them massive doses, likely upwards to 12 times the human high end dose. They did it in a very short period of time. They basically induced massive weight loss with massive doses of semaglutide in a very short window of time. And so these animals lost a tremendous amount of weight very, very, very quickly. And with it, they atrophied everything. Plus, there is some data showing that GLP-1s, and I think this may be dose dependent, it really wasn't clear in the studies, can actually shut down your adipose-derived stem cells, which is like my world of regenerative medicine. I know you and I are both friends with Dr. Sabrina Salt too.
Oh, yeah.
We need those adipose-derived stem cells to work. That's how we turn our, that's how our cells turn into the things we need them to. So that's concerning. I think that may have something to do with why these people who are on these crazy high, lose massive weight very quickly. I think that's why we're seeing them turn into what looks like a melted candle.
Hmm.
They just are melting. It's because I think you take any signaling peptide hormone and crank the dose into crazy high levels, and you're going to have serious problems. So I think they're probably having, and that 40% that we hear about of muscle loss, that's actually lean mass loss. It's not all muscle. It's lean mass. And your lean mass is any of your soft tissues, ligaments, tendons, muscles, nervous tissue. That's all lean mass. And so if we're losing 40% of lean mass with crazy high doses, that's problematic. So this has even furthered my stance that we need to keep the dose as low as humanly possible. That still works. And if it's not working, there's probably a whole lot of other work that needs to be done in order to get that low dose to work.
Yeah.
That's where I'm at.
Yep, I totally agree. And the facial fat too, like you said, the melted candle. You're right. I mean, I see a lot of women with no ass, nothing. I mean, no muscle whatsoever. They're looking anorexic, and then they look like Skeletor because they
Yeah.
lost their facial fat. So they're actually looking 10, 15 years older than they were. And is that the price you want to pay to lose some weight? And I mean, these women are in the subset of people that they need to lose maybe 10 pounds, maybe 15. And now they've lost 20, 25, 30, and they look horrible. They look absolutely horrible.
I think these peptides, this is just totally me just sharing because I have a pretty big audience. So I hear from a lot of people. I hear from a lot of great doctors like you who are utilizing these strategies. I hear from a lot of folks using them personally and professionally. I think that at tiny doses in a metabolically optimized body, I think they work anabolically. I think in a very metabolically compromised body at high doses, I think they are very likely going to turn catabolic.
Mhm.
And for your audience listening, anabolic means building up tissue. Catabolic, think of cats. It means chewing down of tissues. The other thing I've noticed, and I've seen this clinically within my own patient set, and I've heard about it a ton from my audience, because I've got hundreds of thousands of followers all over the world, and they are letting me know. And then I've got doctors who are using this now all over the world. I've got a course that's for the practitioners, but the general public's in it. And I've got hundreds and hundreds of doctors in there. So I'm getting a lot of feedback. And I think it also, I think they're very healing inducing. And an example is myself personally. I have been on 2 grains of Armour Thyroid for longer than I can remember, probably upwards to over 10 years that I've been doing 2 grains a day, one in the morning and one in the afternoon. And before I started GLP-1s, I was hitting a point where I was starting to play with bringing in, at times I'll bring in a little T3, I'll bring in a little T4, and I just could not, no matter how much I cranked up my thyroid, I was just getting tachycardic and jittery. And I was like, this isn't, something is wrong, but I can't put my finger on it. I had the estrogen on board, I had the progesterone, I had the testosterone. Something was not working. I had the low dose naltrexone. I have all the things. I have exosomes. I have access to things that people cannot get access to. And I was putting them in my body. And now, after being on just the tiniest little dose of GLP-1, I'm nowhere near the standard starting dose, by the way. And I've never, like, I would be dead if I tried to take that dose. I would be like vomiting and having diarrhea.
Yeah.
I can only handle half a grain a day, if that.
Oh
Like
my God.
sometimes it's a quarter grain. So these things are very healing and anti-inflammatory and regenerative. And that's been my message since day one. And because my background's in regenerative medicine, I was like, woohoo, this is right up in my wheelhouse. But I think, and maybe you've seen this, to your point, if you don't address the thyroid and the hormones and you give someone even the tiniest little dose of GLP-1, I think it can unmask the problem. Meaning, I think that some people are sitting in this subclinical hypothyroid land, and then you give them even the tiniest little dose without supporting their thyroid, and all of a sudden their hair is falling out and they're having hypothyroid symptoms. Same thing with low adrenal status or low sex hormone status. I think it unmasks whatever is deficient, because this is, again, a guesstimate. And there's probably smarter people out there who could help shed some light on this. I think anytime we ask a pathway to work harder, but we don't provide the other nutrients and other things that are needed for that pathway to work, we're asking for trouble, right? So like giving copious amounts of any vitamin or mineral is an example. All of these things work in harmony together. So we have to give the orchestra of things. It's like giving somebody adrenal glandular without giving them any kind of adaptogenic herbal support along with it, Anyway, it's that kind of view. I'm thinking, what if we're pushing healing pathways, but the hormones are off and it's just kind of shoving them a little bit further too fast? And then we're seeing like the frank symptom picture of that hormonal deficiency. This is just, I'm more asking than I am telling. This is just what I've been seeing. I'm wondering if you're experiencing that at all with your patients.
Well, yeah, I think it comes back to what I said in the beginning of people trying this to hit their symptoms. So we know with, like you said earlier, you become a potato when you go into perimenopause, menopause. When you are hypothyroid, your metabolism slows down. You start to
Yeah.
get the water retention out of nowhere. You get the weight gain, even when you're trying to do all the things. So what women will do is also going back to a point that you made, they go to their doctor and maybe they're being told they're normal, but my doctor said everything is fine. I don't need hormones and my thyroid looks good. It's normal, right? Now you and I would look at those labs and go, "Oh, no, this is not normal good at all. This is not optimal. You're hypothyroid, you're low and slow everywhere. You have no hormonal function." So I think it's what I see are those women trying the GLPs, hoping like, okay, maybe this will help my symptoms that I'm experiencing that no one's giving me answers for. Everybody's telling me that I'm normal. Don't worry about it. It's just part of getting older. But I don't want to accept the extra 10 pounds and the water retention and the inflammation. So they try it and it doesn't work. And so that's where the unmasking comes in. It's like then they
Yeah.
come to you or I and we're like, did you know that you have Hashimoto's here? That's autoimmune. Your thyroid's in the toilet, all the things that we just talked about. And then to your point that I want to talk, I was smiling when you were saying about your armor. I have been able to reduce my dose of T3. I'm T3 only, I don't convert. And I've been on a relatively higher dose for 20 years. It works for me, it keeps me optimal. I'm good, I'm great. But ever since starting to take the GLP, the concern always is with T3, it can
Yeah.
burn a little bit of muscle, right? I'm 50 years old. I want to keep all the muscle that I possibly can. I bust my ass at the gym. I eat the protein. I do all the things. I want to keep my muscle. And so I'm like, I wonder if I can roll this back just a little bit. And I have been able to with no change in how I
Yeah.
feel, no change in symptoms. So it's pretty cool. And I was going to ask you the mechanism of action, like as to the why. Is it improving my mitochondrial function? Is it just that it is improving my metabolism just a little bit at that microdose? Is it taking down the inflammation? Is it helping my autoimmune? Like, what is it that we can now reduce our dose of thyroid?
I think it's healing the gland and it's addressing because we have GLP-1 receptors on our immune cells too. So, I mean, like quite literally on mast cells. I'll tell you a story in a second about another practitioner I was literally just texting with before I came on here. Um, I think it's healing the gland. We know it heals the pancreas, like quite literally heals the pancreas. It quite literally heals heart tissue. So I think it's quite literally not only mitigating the autoimmune process happening in the body, but because I know you know this, and I'm sure you've told your audience as well, but most, 90 some percent cases of hypothyroidism are
Yep.
autoimmune.
Mhm.
Most things that have an immunologic component, including pain. And I think it's quite literally healing the glands. And we have data to support it healing other glands, including kidneys, heart, pancreas. So I can't imagine why it's not potentially healing the thyroid. That's why I think if you don't support the glands that are compromised along with giving the GLP-1, it might be problematic and unmask it because it's almost like putting your foot on the gas, but you don't have enough oil in the tank or some, I'm not a mechanic, but there's something else that's not working in the car, but you're asking it to run hotter and faster. Same thing if you give somebody thyroid and you don't support their adrenal glands, right? Like you'll bonk because you're asking them to run hotter and faster. So I do think for some folks who are having some of these, I get messages from people all the time. They're like, my hair is falling out. And it happened to me too. I had a big hair shed. I also wonder too, there's a big component of the gut microbiome shifting to a more favorable biome. And so that die-off reaction might actually poison you for a second, So
Okay. Yep.
there's just all kinds of things. And I cannot find an exact direct correlation, but it is my hypothesis that it is improving the damage being done by lipopolysaccharides. So the
Mm.
LPS that we're all being poisoned by, depending on our milieu and our genetics. I think that these are also beneficial there. And I think that might be why they're showing improvement across other organ systems. Not, there's like many mechanisms, if you will. We get a couple mechanisms. We get to have the improvement in insulin signaling and the improvement in insulin reception. We get to have the improvement in the AMPK SIRT1 pathways. We get to have mitochondrial improvement. We get all of that. But I do think that it's dose dependent, and I think there's a sweet spot where a little bit is great and too much is too much. And that's why I will die on this hill of keeping the dose absolutely as low as possible. So this practitioner, I got to tell you really quick,
Yeah.
her name is Dr. Christine Schaffner. She's world famous. She's a good friend of mine, naturopathic doctor. She's up in the Seattle area. She treats predominantly those with really complicated chronic illness. So MCAS, Lyme, mold, like she's the girl, right? When you don't know where to go. And she just harmonizes beautifully so many different therapies and modalities. And I got her onto this. I was like, look, I'm very interested in how this would affect your patient base because these are very, very sensitive people and you can barely touch them with anything without them having a reaction because they're so, so, so sick or toxic. And I said I would be fascinated because I have a theory. We do have some data showing that it sits on mast cells and calms them down. I said, I really think this would help tremendously with those people who have histamine issues and MCAS, mast cell activation syndrome. And I do think it would help your Lyme patients because it has such a profound impact on the immune system. That study that just came out in Nature, it was a correlative study, not causative, but they looked at 250,000 veterans. And this is not the only study showing this, decreased infection rates. I have data showing decreased pneumonia rates, data came out in 2021 in the Journal of Diabetes showing 80% reduction in hospitalized type 2 diabetics with COVID, 80 reduction in ICU admission and death. So we know that it works on the immune system and it keeps people from getting sick is what I've seen clinically. And that's what the data is adding up to. So she started, and it's been about 6 months, and she just texted me and left me this long voicemail. And she was like, oh my gosh, this has been miraculous. Because she's seeing all of these patients post COVID are having even worse histamine issues. And so she's been using it to quiet down that histamine in these folks. And they're not only having the weight loss because when you get so inflamed, you just hold on to your fat, and it's like you can't get out of this vicious cycle. It breaks that cycle. And she's using very, very tiny doses and titrating very slowly and just having phenomenal results in this entire patient cohort, the Lyme, all of it. So I'm not in any way, shape, or form saying it treats these conditions. I'm saying it's a tool to help mitigate the symptom picture and to start healing the milieu, if you will. So, and we have data to support everything I'm saying.
Oh yeah, 100%. Yes. Side note, everything that we talk about on the podcast, there is data backing it, right? Although we do like to experiment on ourselves, but
Yeah.
yes.
And I have been not, I mean, up until a month ago, no one in my family had gotten a cold or a flu since I got everybody on a microdose.
Ooh.
And just recently, a little bit of a cold went through my daughter and she ended up sick and got a bit of a cough. But my dad, my mom, myself, my husband, and I've been traveling a ton. This whole year, I've been on airplanes going on podcasts.
Yeah.
And I'm normally that girl that gets struck down with pneumonia and gets hammered with it. I just have my lungs are kind of my weak spot. And knock on wood, like we haven't even had a sniffle. I did over the December, like at A4M, actually, I had a little bit of a like, like this little tiny cough, but it wouldn't manifest into anything. I couldn't even get mucus to start. Like I was almost hoping it would turn into a cold because I just wanted it to go to fruition.
Yeah.
Like,
Yeah.
let's just get this over with because there was this little like for about 2 weeks. And I wonder if I wasn't dealing with like the tiniest little walking pneumonia, but had that been me prior, I would have been like still coughing with walking pneumonia. So
Yeah.
it's doing some pretty cool things in the immune system. And I do think it's protective. And now we're having data show us that it is indeed protective to the immune response and less infection rates with things. So
That's
pretty
incredible.
cool.
I've not heard that, but that with the data and with your anecdotal evidence is absolutely amazing. Now you had mentioned about the gut, and that brings me to a question. about GLP deficiency and is there such a thing? So I have a couple of my MPs taking your course, and the one came to me. Now she is 70 years old. She had had gastric bypass in the past. And she said, I honestly believe now she's on a microdose of GLP. She said, I honestly believe I am and have always been GLP deficient. And that's why the gastric bypass worked, but it didn't. Worked, but it
Mhm.
gained the weight, some of the weight back. Now, when she first started with me, of course, we were working on thyroid and hormones and all the things. But she really feels that the microdosing of the GLP is actually addressing a deficiency that she's had her whole life.
I have no evidence to support that statement, but I feel the same.
Okay.
And it's been very bizarre for me because when I stumbled upon this, that was my first thought. Like I mentioned, the functional deficiency at the very least, right? Like some kind of functional deficiency. But even going further, are people genetically lower? And is that why and are we get as a society due to our modern living and our toxin levels and just, I mean, our generation, we're the same age. Our generation had an entirely different experience on this planet in our early years than did our children, right? So we're getting more and more toxic. We're dealing with more and more just the fuckery, I call it.
Yeah.
It's just all the fuckery. The vaccines, all of it. It's all more, right? There's
Yep.
just more, more, more. Just pump these kids with more. The foods, everything's adulterated, right? I wonder if that isn't contributing. So again, more than anything, I do firmly believe there is some functional deficiency. But then I look at folks like my sister and Oprah Winfrey and some other folks out there that, although aren't even the same ethnicity, almost have a same look about them. And I can't even describe it. There's like a certain look. And I have talked to people, I've talked to colleagues, I've talked to my followers. And when I see that look on their face, I say, have you tried GLP-1s? And they either haven't yet or they have, and they go, oh my God, it changed my life. And they have all had the same experience, which was like something was missing and now it's not.
Mm-hmm.
And I think that there's a phenotype, if you will, of it's not just obesity. I think there's a phenotype of low GLP-1 and it turns the lights back on for these people. And they've all said the same thing, which is, I feel normal now. So I don't know. I don't, I don't know. I don't know if there's like a frank, overt deficiency. We can't run GLP-1 levels on people, so it's hard to tell. I've had some of my friends who are deep into genomic medicine tell me that there are actually SNPs, single nucleotide polymorphisms, that code for GLP-1. And so they are kind of correlating that in their practice. So I think this is all very new. And the only time I've been able to get in an actual room with a bunch of practitioners utilizing this strategy was at the Mindshare event where I got to speak on that panel. And there were a whole bunch of practitioners in there who all started using it for different reasons after I came out and started talking about it. So some of them are treating just exclusively type 1 diabetics and having phenomenal results. And
Mm-hmm.
others are treating, they're more into the rheumatoid arthritis realm of their practice. So just like across the board, I got some incredible feedback from those practitioners. So I think it's too early to tell. What I will say is to everyone listening, I'm not even, I wish I'd never said the word microdosing. This is really just a personalized dosing strategy, which is, and if the pharmaceutical companies were smart, they would figure out a way to realize that there's a whole cohort of people who could really benefit from these peptides potentially. And they should, and there's, even if it, I understand they have to do what's FDA approved, we're allowed to use things off label. And even for the FDA approved cohort of people who are dealing with obesity and type 2 diabetes, those people cannot always tolerate the standard starting dose. It's too high for them. It makes them so, so sick. They're missing out on a whole group of people they could be helping if they really, I know they're really coming up against the compounded version, which is the only way to get these more personalized dosing strategies right now. And
Mm-hmm.
so to the big pharma companies, I say, like, consider that there is a whole group of people who could, we have the data on the cardiovascular improvement. We have the data on so many things, lowering, I mean, really across the board, we've got a few signals showing very, very tiny amounts of people in the overall cohort of the study having some suicidal ideation, but we have multiple studies showing a decrease in anxiety, a decrease in depression, a decrease in suicidal ideation. A study came out on children showing a significant decrease in suicidal ideation because, of course, I mean, these were obese kids. Of course, like I could not imagine going through life in an obese body as a child and dealing with that. Like, what kids are cruel, like
Oh,
what is that
yeah.
like? And not being able to do sports or feel comfortable in your body or, that's a whole other conversation. But, and I don't say that I'm not an obesity specialist. I've never lived in an obese body. So I want to clarify there. But that said, I think that we're missing a whole group of people who could really benefit from these peptides if they were made available in a more variety of dosing
Yes.
options, and
Yes.
including starting them out lower because maybe they do need to go up to the standard dosing, but they have to start somewhere and not be dying sick to get there. That's not smart.
Right.
It's just not
Yeah.
smart
No,
medicine.
not at all. There is so much in there that you said. So I want to touch on a couple different points that popped into my head. Number one, I mean, really, we could make this all stories plus data. And I think the stories are fun because it's what we've experienced or what we've experienced with our patients too. The one nurse practitioner that I told you about that's in your course, she was telling me the story of how she had a patient who had rheumatoid arthritis. And she was working with this patient on starting a GLP at a microdose, at a very low dose. Well, the woman took it incorrectly. You got those
Oh
syringes and the
no.
milliliters and the zero point 0.5 and the 0.05 and the whole thing, right? So she ends up giving herself, maybe it was a standard dose or maybe even a little bit more. Well, needless to
Oh
say,
no.
she was sick as a dog. However, the pain that she had experienced for 20 years disappeared. And even when
Yep.
she went back on the microdose, it stayed gone.
Yep.
Crazy.
Yep. Yeah.
Crazy.
I will say this to the compounding pharmacists. They all message me and say, "What's the dose?" I don't know what the dose is, you guys. The dose is individualized for the person sitting in front of me. The patient sitting in front of me gets the dose that I think they can handle.
Mhm.
And it's all based on their constitution. Like how sensitive are they, right? And what are we trying to hit at? What's our short-term goals? What's our long-term goals? But that said, a lot of these compounding pharmacies are making super concentrated compounded versions, and those are very difficult to titrate down to tiny little amounts. So I say the same thing that I said to Big Pharma a minute ago to the compounding pharmacists. Start producing stuff at a 1-to-1 ratio, like 1 milligrams per ml. Like that is so much easier, especially for some of these elderly folks. Like my mom, I worry every time I tell her, like what to pull up on the syringe that she's going to eyeball it wrong. Because
Right.
sometimes we're doing little tiny increments and a little too much is a lot too much for some people. For myself personally, I did a tiny little bump in my dosage through the winter because I just didn't want to get sick.
Mhm.
And all of a sudden it's like night and day. You're good 1 minute and then you're in a wasting state. Like I literally look in the mirror, where's my butt? Like, why does my face look gone? So the tiniest little bit too much is way too much in some people. And to all the practitioners listening, heed my warning. This is
Yeah.
a very slow and low process, as should be any hormonal intervention or peptide intervention, in my opinion. I think a lot of the peptide dosages we see with some of the other, especially in the bro science community, I think a lot of them are way too high. And middle-aged women in particular, we're a sensitive group.
Yeah.
Like we just are, we're stressed the F out and we're a sensitive group. And you always can add a little more. You can't take it away. So for any peptide, for any hormone, I always titrate up to the lowest minimal amount needed to get the job done. And I microdose everything. Like we might microdose the testosterone.
Mhm.
I'm going for, if I'm using testosterone, I'm usually looking for a little bit of an anabolic impact. You
Mhm.
don't always have to do standardized dosing to get there. Like we don't have to drown. It's like the kitten, when people squeeze the kitten till it dies because it's so cute. Have you heard of that? Like it's a syndrome where you squeeze something that's so cute, it like overwhelms you, but you end up killing the poor kitten. Like don't choke the kitten.
Right. Don't choke the kitten, please. Thank
just
you.
I'm a naturopathic doctor, so we nudge, if you're doing it right, we nudge our patients to wellness. We don't slam them, right? So I'm just looking to give them, I'm looking to sweeten the deal. And in the meantime, they have to be putting in the work because really this all comes down to the work. All of these things work so much better, if at all, if you're putting in the work. If you're not putting in the work, you are reliant on that syringe forever and it will eventually probably stop working so well for you. On that note, though, even with my one patient who I've shared about my dad, he's the only patient I've treated with severe obesity with these peptides because I just don't run in that world. I mean, I might have a woman with some, she's overweight to some degree, right? Like I'll have a patient here and there, but I don't deal with like severe obesity like my dad. And I still only have the guy at like half of the, he's right in the middle of the dosing tiers.
Mhm.
And I think there's something about time, like the time on these peptides matters because I think it does start to heal things. And so
Yes.
time matters and it concentrates in your system a bit over time. So there's like, you got to be careful because you're fine, you're fine, you're fine. Then you're puking, so there's a way to do this that's elegant that I teach in my course, but also just time on them, I think matters. And so it took about 9 months and all of a sudden the weight started melting off of him, but it was a little too fast. So we had to back down the dose, right? So like be patient if you're the general public and you're trying this strategy, just be patient. It's time. It takes, these are not fast working peptides. It's cool that that lady had that experience with her pain. I'm sorry she got overdosed, but it's still like she will be much better in 9 to 12 months from now than she even is at the beginning, right? So just giving things time and trusting the process, it works even for weight loss. I've got several of my own colleagues in my profession who are like, Tina's strategy doesn't work. I'm like, well, how long did you do it? And did you do all the other things? Because from my knowledge, most of the naturopaths don't know how to deal with hormones. Most don't. So, and they certainly most definitely don't have a clue about metabolic health, for the large majority. So like, no, we're not doing all the things, right? You got to be strength training. You got to be sleeping. You got to be eating nutritionally dense food. You've got to be getting sunlight. You've got to be, getting the other hormones in line.
Literally all the things. And what I tell people is you have to eat protein like it's your job. Now, I shouldn't have to say to that person doing microdosing correctly, I shouldn't have to say force your protein, right? So back in the days of the higher doses of the GLPs, I would say to a woman, I don't care if you have to do 3 protein shakes in a day because you look at that steak and you want to gag and you can't take another bite.
Yeah.
Then you blend a shake and you drink it down and you
Yeah.
get that protein in. But realistically, if you're doing microdosing properly, you keep your appetite. You don't
Yes.
lose your appetite. And
Yes.
and I don't know about you. I mean, I would say not snack as much, but I do not lose my appetite. Whereas when I was doing the
Yes.
higher doses, it was exactly that. I would take a bite or two of this beautiful ribeye and be like, I can't even. Like, and it was
Yeah.
the weirdest feeling ever. But I think that's an important point is you also have to be eating the protein, no matter what dose you're on.
Yeah. Well, we want to stay on this side of appetite suppression. We just want appetite control.
Yeah.
If that, like I have just the slightest touch of appetite control. If I were really using these for weight loss, I'd have a six pack abs, but I don't. Like I have some fat on my body because I'm 50 and I know that my fat is actually my estrogen depot and I don't want to lose it all, and
Mhm.
it's not a beautiful look for a middle-aged woman to get super, super lean. Their face, you got to start filling it up with filler then. So I'm trying to like me and said it cured my anorexia, which you think would be the opposite, but we're not dosing into appetite suppression. We're just dosing into appetite control. And I think part of anorexia and these eating disorders is also dysregulated signaling in the brain of your appetite hormones. And so it corrects for that, whether you're an overeater or an undereater, it corrects for that. And it's really remarkable. And so I've had a very similar experience to what they have shared with me. It was like, oh, I actually just feel more in control about food in general. It consumes you when you're an overeater, it consumes you, and when you're an undereater, it consumes you,
Yeah.
and it just doesn't. It's like the noise is gone across the board. I will say though, something else I have realized totally is that you for us girlies who are have been super super low carb for a long time, it, I don't think that flies. I don't know what your clinical experience has been, but when I get these folks on a microdose, that they can really have their blood sugar bottom out unexpectedly, even on the tiniest doses. And so, like, usually around day 2 or 3 after their shot. And so, I really encourage these women to bring carbs back into their life, and they're
Mhm.
usually very happy to do so. And it's the carbs are managed appropriately. Like, because if you're low carb, super low carb for a really, really long period of time, you can damage your metabolism,
Yeah.
and you literally low carb or no carb yourself into insulin resistance, which is what I did to myself after decades of no carbs. And so I really encourage these ladies. It's a because I think you completely destroy your IgA in your gut,
Mhm.
and it's just a very devastating place to be. And then you're just completely burned out, right? And these women are hard cases to treat and get them back online. And so, especially if there's a history of anorexia there, like, or bulimia, they've really done some damage. And so I have found that in this group, if we just give them some carbohydrate back into their life, maybe in the form of sourdough bread, like real sourdough bread, just like the
Yeah.
good
It's
carbs, they are so happy, and it brings a sense of calm, and they're like, oh, and then the GLP-1's even more tolerated. But this is
yeah.
again in that really metabolically optimized crew. I'm talking, some
Mhm.
people really do need to go lower carb just in general because they've been carb junkies for a long time.
Well, yeah. Yeah, it just all depends on what they're doing right now. But you're right. When you
Yeah.
take someone who's been doing keto or carnivore, it's almost like they become addicted to that lifestyle. They are fearful of adding carbohydrates in. So you almost have to let them experience that blood sugar low. And then you go, okay, are you ready for some berries and a sweet potato and sourdough bread
Yeah,
now?
right, right. Like, go for it. I
Yeah.
just had to take my dear, dear, dear friend off of her long-term carnivore diet. Like, she's had 2 babies on carnivore. And then I got her labs back, and I was like, your body is stressed the fuck out. And your
Mhm.
lipids are starting to do funny things. Like, this is your carnivore. Like, eat some carbs.
Yeah.
Put some back in.
Please. Yeah. Yeah, exactly. Now, you had mentioned something earlier. I want to circle back to this about kids. So,
Yeah.
Callie Means, I
Yeah.
love him. He's outspoken. If y'all have not heard of Callie Means, oh my gosh, he's been interviewed across the board, Rogan, and he's really, I mean, he actually was the catalyst for getting RFK Jr. to join Trump and his forces. So it's kind of a cool story. But the one thing that he says that I really want to get your opinion on is, oh, we're putting all these kids on GLP-1s right out of the gate who are obese. Like, that's the first line of defense. Okay, I understand not starting an obese 12-year-old on, let's say 5 milligrams of Manjaro. But what about the microdosing? This could be a way to get these kids out of the pharmaceutical realm, because his point is, okay, you have a kid started on pharmaceuticals, you have basically a cash cow for life, because it's not going to just stop with the GLPs. It's going to go into the blood pressure med and the statin and the antidepressant and the sleeping pill and all the things that obesity brings on. But what's your take on kids doing the microdosing?
Well, first of all, I will just say, with all due respect to Kelly, because he was a friend before all this started. I don't know if people go listen to my debate with him on Mark Hyman's podcast, first of all.
Oh,
And
I did not know that. Oh, I'm gonna go listen to that. Okay.
yeah, he yelled
Okay.
over the top of me for a good portion of it. So, number two, he is not in any way, shape, or form have any health credentials whatsoever. And he's never seen a patient and has no clinical experience. So, with all due respect to anybody in that camp, they don't get an opinion in my book until you've had an obese child sitting in front of you and you see the damage it's doing to them psychologically and physically, because they will be on all those pharmaceuticals regardless. The
Mhm.
other thing we have to consider with childhood obesity is that these children were usually born to obese moms, and they were bathing in vats of insulin inside that placenta, and they have been epigenetically marked. We have all the data to support this. Lily Nichols is a dietitian who specializes in metabolic health and the pregnant and prenatal woman. She's written several books on it. She's fantastic. She's been on my podcast. You should probably have her on yours. She talks about the impacts of what happens to the baby in utero of the metabolically compromised obese woman. And these kids are epigenetically marked for life to have the rates are astounding, and I will get them wrong, but they were crazy high. These kids' risk for obesity and diabetes in their life is like massive. So these kids are already marked for this life. And the whole eat less, move more. And Kelly is a big proponent of lifestyle intervention, as am I. I mean, he and I have been preaching the same thing up until recently. And you can you can try to metabolically optimize these kids all you want. I think genetically and epigenetically, they are marked and they have all bets against them. And it's also just an absolutely devastating place to be for these young people because they don't have control over what their parents are feeding them. He also doesn't understand that. We tried to talk about that on Mark Hyman's podcast, and he got, I don't know if they kept it in the final edit. I can't watch the final edit because it was difficult. It was a difficult process to go through, and like, just go watch it. You'll see. I kept my composure, but I tried to bring up the point with him, and Mark agreed with me that the bulk of obese kids have obese parents.
Yeah.
And he didn't want to hear it. He said, parents aren't trying to poison their kids. And I was like, no, I never said that, but they're living in a household where they cannot control the food environment. The parents are controlling the food environment. Childhood obesity is such a massively more complicated picture than we give it credit for. It's not just let's get these kids moving and feed them better. That would be all well and good. But they are metabolically compromised from the time they're in the womb, right? And I think GLP-1s are a beautiful intervention. He's also very incorrect. He's trying to go on the, most recent obesity guidelines, the American Childhood Obesity Guidelines. I don't have the exact term right. And he's saying that basically what happened is they approved GLP-1s for weight loss somewhere around, I think, 2023. And his whole argument is that they're saying it's first line. That is absolutely incorrect. If you go read the guidelines very clearly say, and I've listened to so many obesity experts talk about this on different webinars and different, because you and I have to get CEU, right? We've got to get all our continuing education. And there's one happening right now, a webinar that I'm not on because I wanted to be on this podcast instead. I'll listen to the replay, but they always go after lifestyle first. And it's a very complicated process. And these guidelines very clearly say, like, address the diet, address the psychological impact, the amount of hours that they suggest for the entire family to go through therapy together. Like, this is not a simple process. And for those who don't have all the time in the world or have close access to these resources, because these types of resources that are needed they're few and far between. There's not like childhood obesity clinics just hanging out with skilled practitioners in them all over the country. And not every parent has time to take their kids for these types of things. So all that to say, pharmacological intervention is way low on the list. It just got approved. That's all. It got approved. They basically said, if you need to bring in pharmacologic intervention, it's now part of the guidelines. And he's twisted it into a story that it's the first thing they're going to do, and this is the worst thing in the world. And I disagree. I don't think he's telling the whole truth. I don't think he understands what the whole truth is. And he does take snippets of studies and sensationalizes them on his social media without reading the study. So.
Okay. No, thank you for clarifying that, because I'm with you. I do believe that if we can help children get out of this obesity epidemic that we're seeing, and like you said, I mean, we've already touched on it, all of the disease states that come on from having obesity, the psychological and social implications, the bullying, the cyberbullying. I mean, it just goes on and on and on. So if we can do something and use a drug, a peptide, essentially.
A peptide.
A sequence of amino acids in a child to get them out of this state. My God, why wouldn't we?
Well,
to potentially keep them off of the pharmaceuticals in the end.
The study from last year that came out showed, like I said, significant decrease in suicidal ideation with the use of GLP-1s. And then the study that came out last week in Nature, this was in the veterans, the male VA, but it showed a decrease in 42 different disease processes. This was, again, it was correlative. They took like 1 million plus people, 250,000 roughly of them were on GLP-1s, whether it was liraglutide, semaglutide, tirzepatide, and then they followed them for like 3.6 some years. And there was some increases in some things we don't want. Like there is a real risk for pancreatitis. But the number one cause of pancreatitis is gallstones. So I'll get back to that in a second. But anyway, they followed them and they found a decrease in 42 different disease processes. So the from the time I started talking about this, I took a tremendous amount of heat for talking about this online. It was insane, like the amount of venom that came at me till now, which is like a year some later. This data has been really remarkable. Like this is pretty conclusive across the board that these peptides have tremendous potential in so many different avenues of our health. But that said, too high, too fast of dosing is a real problem. And if you stop eating, if you get dosed so high that your appetite gets crushed and you stop eating, and then what happens? Your gall bladder, your bile in your gallbladder gets sluggish, right? And these are people already on the edge of gallstones or more prone to gallstones. These are already people with fatty liver. These are people already with fatty pancreas because of their metabolic compromise. And then you put them into this like this forced caloric restriction because you crush their appetite with the dose being too high. And then they get gallstones and then they throw a stone. And where does the stone go? It gets thrown into the pancreas and we get pancreatitis. And so in this cohort of people, they did see a significant increased risk of pancreatitis, but this was also older veterans. And we don't know, were they drinkers? Because that's another big cause of pancreatitis is drinking. Are they drinkers? Are they smokers? How obese were they? How long had they been obese? You know, all of these are details we need to know before we say, oh my gosh, this increases your risk for pancreatitis. I think it definitely could in the wrong patient set or if it's not handled appropriately, right? Again, I think that's a management issue. I think if you have a history of gallbladder issues or pancreatitis, I don't think GLP-1s are off the table. I think they just have to be done very low and slow. And you have to address your gut health and your hormonal health and all the things we've been talking about in addition.
Yeah. Yeah. All right. Thank you. I'm so happy that you touched on that. I want to jump to the mental capacity, the mental impact that the GLP-1s have as well, because another story, I have another patient started on microdosing GLP really for just all the anti-inflammatory benefits. Obviously, she has Hashimoto's. We wanted to reduce her autoimmune reaction. But the one unexpected result that she experienced was really like total improvement of mood. And
Yeah.
to the point where she was not on an antidepressant, but it was kind of one of those you don't know that you're low level depressed and borderline anxious to where it's affecting you until you're not. And when that fog lifted, when the depression lifted, she's like, I have never felt so good. This is absolutely amazing. And that was the first time that I saw that almost like a serotonin shift in depression. And I can only assume, and I want you to expand on this, is it the impact of the gut and the gut brain connection that is giving people the better mood and the lifting, almost acting like an antidepressant?
Well, it definitely decreases neuroinflammation. It is neuroregenerative in the brain. The impacts in the studies on Alzheimer's and dementia and Parkinson's there's many studies actually.
Mm-hmm.
And they all show very similar benefits, which is calming down the oxidative stress in the brain, calming down the microglial activity, calming a lot of things down in the brain when the brain's going haywire and is inflamed. So that's like a big part, right? Because inflammation in the brain, I think, is probably the biggest driver of depression and low mood. And then number two, the impact on the gut and the potential impact on the LPS, right? I think that is interesting because LPS from your gut is going up to your brain and wreaking complete havoc. So there's that piece too. And then the reason that it helps mitigate the food noise or any of the noise, I mean, it's showing efficacy with addiction of opioids and smoking and alcohol. And those studies have all just come out too, really strongly. So I think that there's definitely an impact on the dopaminergic pathways, on the serotonergic pathways. You're getting the whole gamut. And there's GLP-1 not just made in the gut and then going to the brain. There's actual GLP-1 being produced in the brain. So I would assume it's probably binding and is important in the brain, just directly without ever leaving the brain. And it's not just appetite and satiety centers. Everyone's like, oh, that's how it works on the brain. I don't think we understand how all it works on the brain, because I had the same exact experience personally, and I've had many patients report the same. It just takes the crazies away, like that crazy, overwhelming anxiety that we get so wound up in. It just like, just streamlines it out. And I would even go further to say that the folks that I've used it with, and then many of the people I've heard from online, I've heard from a lot of people saying this too, like they were able to go off their antidepressants or bring them down, the dosage down. But a lot of people have come in and said it just really calms down the ADHD. So I think the impact, that anti-inflammatory impact on the brain, plus everything else I just mentioned, is somehow working in concert. But I do think too, if you take too much, it can really flatten your affect, and it can take you to a place where you kind of just don't like, you don't want to eat, you don't want to drink anything. It really does actually play on your hydration centers of your brain, where like you have to purposely drink extra water when you're on them, because you'll forget to drink water.
Mhm.
My husband, if he takes just the tiniest smidge too much, he like doesn't want to have sex. He's not interested in much of anything. He just gets super flat and wants to lay on the couch. And we do have some studies. Again, they're correlative, not causative. Like I said, the World Health Organization released one. It was like 3 million some people that they looked at. And of that, like a couple hundred had suicidal ideation, but those folks were also on antidepressants and benzos. And so I think it's important, and this is what some of the other studies coming out have also said, don't stop prescribing them. It's not causative. In fact, we have more studies showing it helps improve mood than makes things worse. But that said, if you have a patient who's dealing with mental illness or not feeling well overall, mentally, and who knows what the dosages were that they were on? I mean, did they basically dose them into flat affect, you know? And the other thing I'll say about that is, a lot of people use food as their dopamine boost, and they
Yeah.
use food to self-soothe. And you can dose yourself, like you were saying about the ribeye, you can dose yourself to a point where you're disinterested in food. And for someone who's a foodie, or someone who has a lot of joy around food, or maybe has a lot of joy with cooking food, like if my husband takes too much, he's the cook in the house. If he takes too much, he stops cooking, and then I don't eat.
Nobody's, damn it.
But I've heard people say, like, I'm a real foodie and I love cooking and I love hosting and all of that. And I just don't want to do any of that on GLP-1s. And I've had other people tell me that all their girlfriends are super boring. Nobody, like in Scottsdale, nobody will go out and have dinner anymore because they're all on GLP-1s and they don't eat anymore. So I think you're really taking a lot of culture out of people's lives. And also, if they're using food to self-soothe and then they just are no longer interested in it, how are they self-soothing, right? So there's a lot of things that need to be considered. And I think just working really intimately with your practitioner and always going slow and low and just being aware that these are real potentials, then I think things are fine. But we do need to screen our patients appropriately. But that's for any, I mean, that's for any intervention, right? Like, know
Right.
who you're working with.
Oh, yeah, 100%. And then all of this whole entire conversation really comes back to that saying of the cure or the poison is in the dose. I might not be saying
Yeah.
that correctly, but that's basically it in a nutshell. Like you can either be helped or hurt all in that dose. And to your point about your husband, just a little bit more. Oh my gosh, that's the impact that it can have between, loss of interest in sex and cooking versus living a normal, happy life.
Yeah.
And yeah, yeah,
Yeah, and I imagine the other argument I've heard, which I think is valid, especially because again, we're talking about two different groups of people. You and I are discussing really tiny doses or personalized doses over here in a group of people who are having all of their health uh, addressed in a holistic fashion versus the average Joe out there who's been dealing with a severe pathology of diabetes and obesity, and they're getting dosed in crazy high doses, which maybe they need. I don't think we need to, I rarely have found the need to go super high, of course, but like, and I'm hearing that from a lot of people who use them for a long time. Like a lot of the peptide community also say, like, we just need to, like the lowest doses to get weight loss to come off. But again, they're treating it the whole person. Um, but I think if you consider how I think it can make people more compliant. And a tiny bit of that might be nice and welcome. I know it is for me. I'm not more compliant, but it just calms me down a little bit. But I
Mhm.
think a wampum dose, I mean, you could turn people into zombies, right? And we already have the bulk of our nation showed us over the last 5 years that they're not free thinkers.
Mhm.
So I don't think we need any more of that, right? So that's the argument I'm hearing in kind of the like bro science world too, and like the Joe Rogan world of, well, we're just going to dose people on Ozempic into ambiguity and they're just going to be easier to control. But it seems like people are already pretty easy to control, so from
Yeah.
what I've seen. So I think, again, that supports my argument of keeping the dose as low as possible because we don't want people over here just like, meh, whatever, you know.
Right. Right. That last question, I mean, I could talk to you just for hours. We could seriously talk for hours, but I have to hit this question before I let you go
Okay.
on the cancers. So it kind of ties back into the dosing. In the very beginning, when these came out, do not use if you have a history of medullary thyroid cancer. And of course, my community doesn't want to touch it because of that warning. Now, everything that I even learned back then was the cancer data that they were stating was based on kind of like the poor rats where they blew up their heart. They were using super physiological doses on
Hmm.
rats that then showed an increased risk of cancer. Are there any ties at all with personalized dosing and increased risk of cancer?
Well, so the black box warning, like you said, is on rats, and they gave them crazy high doses. And these rats, it's important to note, rats have they spontaneously develop medullary thyroid cancer, which is a very rare type of cancer in humans because we don't have the same receptor. So when the GLP-1 hit these receptors in these rats, they saw an increase in this medullary thyroid cancer. What they failed to tell you was that the control group also developed spontaneous medullary thyroid cancer. So I have no idea how there's a black box warning on this for rodents when there's not a black box warning on the intervention that was mandated upon the United States for the past few years. But I digress. So in humans, they have looked and looked and looked and looked and looked. And there's one study, the title's very misleading and it was very poorly done. It is also correlative. They saw an uptick in thyroid cancer in the GLP-1 group as compared to the control group was also on medication. Like it wasn't a just clean control group of no medication. So that was interesting. And that was a couple of years ago. And it was a very small group of people. So the impact looked big. And all that to say, since then, several organizations have done meta analysis on all the data that's out there. And it's fairly conclusive at this point that there is no link in humans to medullary thyroid cancer. That said, if you have a personal history of medullary thyroid cancer or another condition called MENS, or a family history, obviously proceed with caution and talk to your doctor. There's no data on these lower doses. To my knowledge, no studies are being done on lower doses. They're all on standard doses. And in many cases, they don't tell you what the standard dose is. They don't tell you, was it 0.25 milligrams or 2.5 milligrams of
Right.
semaglutide? They don't tell you. So most of these studies. I am not concerned, but obviously, just to be prudent and responsible, talk to your doctor and make sure that you're addressing this. But if you look at the actual data, especially that's come out in the last year or so, there's just no link to humans and thyroid cancer. So there's this black box warning scaring the crap out of people, and it's on rodents, which
Yeah.
doesn't translate to humans. So,
Well, and then when we're talking about all cancers, the 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 basis of cancer is that it feeds on glucose. So naturally, when you think, oh, wait, let's see, a GLP-1 is going to improve our insulin sensitivity and lower our blood glucose, we're not feeding the cancer cells anymore. So I would actually argue the opposite. And I mean, we can put the medullary thyroid cancer, like you explained, it's a rare cancer in humans. Let's separate it over here. Let's look at all cancers, which is another something that I've heard from people in that it increases the risk of all cancers. Well, how?
no, it decreases.
Yeah,
Actually,
right.
a couple studies came out last year. One was showing a decrease in colon cancer, and another by the same group, I believe, looked at, I think it was 10. One article I pulled up said 13, but when I went and looked at the study, 10 different types of obesity related cancers were decreased. And again, they're looking at chart notes of people who've been on it for a period of time. And they also, to be fair, they were comparing it to insulin, and insulin is pro-grow. So it's hard to say, but in this study, it showed a decrease. Also, the big cardiovascular study that came out, and I know it was funded by the pharmaceutical company who makes the peptide. That study looking at middle-aged people who were overweight, they were not diabetic, which I find hard to believe because they obviously were on their way to diabetes. Like you will eventually get there, right? Like it's just a matter of time. Even in the metabolically healthy obese, that's a misnomer because give them time and check on them in 20 years and they will have diabetes and they will be metabolically compromised. We know the data is showing that. So anyway, in this group, there was a significant reduction in cardiovascular disease. And also what they found interestingly was a reduced rate of neoplasms. So we don't have causative data saying GLP-1s decrease cancer or GLP-1s decrease COVID, but the data is at least looking like it's trending that way.
Very nice. Yeah, that's what I thought. I just wanted to hear it from you and ask an expert to put it out there to the world. So thank you. And thank
Yeah,
you
I
for
mean,
your time today. My God, this has been amazing. Oh, go ahead. What were you going to say?
oh, I was just going to say, I think that anytime we hear these sensationalized headlines, we just need to go look at the data. I just want to give thank you for what you just said. I didn't want to interrupt, but I want to share this. I just saw, well, I won't name names, but I have seen two really well respected. One's an evolutionary biologist who I know knows how to read studies, and another is a famous physician who specializes in brain health. And I've seen both of them recently just make really egregious claims and sensationalized claims based off of a study, which I believe they're doing it to. I know they know how to read studies. One of them knows how to conduct studies. So I know they understand studies. And I feel like it's just another way to get clickbaity followers because the one brain guy was talking about suicidal ideation, a study that just came out. And again, it was based on that same data set that I was talking about earlier with suicidal ideation. They reevaluated it. And yes, they saw a tiny little increase in ideation, but they actually saw a decrease in suicide attempts and suicide like success, if you'll call it. I forget how they phrased it, but those actually going to fruition. And so, but he failed to say that part.
Uh, yeah. Yeah.
So the whole conclusion of the study was don't throw the baby out with the bathwater. Here's the limitations. It's correlative, not causative, and just keep an eye on your patients. And also, it actually is lowering actual attempts. So, I mean, it's just I'm not saying it. I'm not saying what he said was all wrong, but like they fail to tell you the rest of the story.
Yeah.
And so if you're hearing this, I have a ton of content on my podcast where I go into this, and I hope people will just take a moment to stop listening to these sensational headlines. And if you don't know how to read a study, put it into Chat GPT and ask Chat GPT to analyze it for you.
Oh, yeah, that's
we're
right.
just we're getting a lot of people hating on these peptides because I think there's an extreme amount of fatophobia in this country.
Mhm.
And people, I don't know why. I don't know why we will think it's okay to put somebody on a statin drug or a beta blocker or any of these other drugs that are lifetime drugs because that's how they're being prescribed. And they are for lifestyle induced conditions. But when we actually have a peptide that's not a drug, it's just a peptide that happened to be co-opted by Big Pharma. We have a peptide that could potentially actually heal these systems and decrease the need for all these other lifestyle pharmaceuticals. People are just shitting all over it because they have some kind of personal issue with it. It's bizarre. So that's all.
It is bizarre though. And like you said, the people that are shitting all over it, I can't figure out outside of the sensationalism and the clickbait from practitioners or influencers out there talking about it. I don't understand the mental block of some people who poo-poo it. And many of them haven't looked at the studies, haven't even tried it themselves. They just have that mental block. The GLPs are bad, GLPs are cheating, and they won't go anywhere near it, and they'll poo-poo anybody who does.
It's intentional ignorance at this point because I have put a ton of content out into the world to get the truth out. And so they're just choosing not to listen to it.
Exactly. Exactly. So, Dr. Tina, like you said, you have your podcast. And then what about the course that you have? So, you mentioned earlier it's for practitioners, but it's also for lay people that just want to dive in more. So, can you talk about that?
Yeah, so I have a free educational training called Ozempic Uncovered. It's on my website at drtina.com. It's right up there in the banner. It's right down, if you scroll down to, it's right there on the front page. And it's a free 4-part video series that goes deeper into the multiple uses of this peptide, the dose makes the poison. I talk a little bit more about that. I talk about the big scaries. I cover them all in more detail, the big ones you're hearing about that people say, oh, it causes this and this and this. And then it takes you into the opportunity to buy a course, which is beefy. I made the course originally for practitioners and health professionals of all sorts because I know that we're all working with people on these peptides. These peptides aren't going anywhere. And I talk more about what goes into a comprehensive treatment program. So there's a whole module on hormones. There's a whole module on exercise. And I tie it always back to the GLP-1 and how the GLP-1 can assist with that as well and sweeten the deal. But these are just one tool in a toolbox. And so learning about the entire toolbox. But then I was talking to Sabrina Solt, Dr. Solt, and we both agreed that most practitioners don't have a clue how to address metabolic health either. And there's a lot of really smart followers out there. There's a lot of really smart men and women, especially my female followers who are like really want a high level of education. And so I just decided to let everybody in the same course. And so it's beefy and it is geared towards practitioners, but I've got little old ladies in there that are in their 70s and upward and they're like, this is the best education I've ever gotten. I wish I'd had this 30 years ago, you know. So I really try to it's how I treat patients in my practice. And my practice is now closed to anybody new. So like, if you want to know how my brain works around practicing and how I address a patient and the steps that I take to optimize their metabolic health, and then utilize GLP-1s appropriately and keeping that dose low. That's the course. So a little, tons of free content on my podcast too, the free 4-part video series for people who don't want to purchase anything. There's a lot
Oh, yeah.
out there.
Ton of information. You give a ton of
Yeah.
info.
And if you want, we could do a coupon code for 20% off and make it Dr. Amie if you want to
Sure.
do that. For
Let's
the
do that.
people. So when you get into the 4-part video series, you guys, if you go that route and you get to the point where I offer the course a few days in, just use Dr. Amie as the coupon code instead. It'll give you a bigger discount than what is available in the little funnel there.
There you go. Cool.
Yeah.
Thank you. Thanks for that. And we'll put that in the show notes too. We'll put all your links in the show notes as well. So,
Awesome.
oh my God, this has been so amazing. I love you to death. Thank you so much for your time. I mean, if anything, this was kind of a selfish conversation because I just enjoyed sitting here shooting the shit and learning more from you and talking all the things because we're like-minded, but now people just get to listen to it afterwards. So bonus.
Well, thank you for having me. Thank you for being patient with me scheduling with you. I didn't ever mean to make it feel like I was blowing anything off. I was just I've been chasing my tail the last year on all these podcasts. So I wanted to be able to sit down in a calm state and speak to you. So,
I get it. No, I get it. And like you said, timing's everything. So now we have even more data and more stuff to talk about. So there we go.
yeah.
Yeah.
Yeah. Thank you.
Thank you, Tina.